How are doctors using Faricimab in real-world settings? The IRIS Registry has a few answers.
I'm Greg Notestein with Scott Chriswanis, and this is New Retina Radio's ARVO 2023 coverage from Retina Today and Bryn Mawr Communications. We sat down with Dr. Durga Borkar to hear what researchers in the FARETINA-AMD study group found regarding dynamics related to Faricimab's use in wet AMD patients since its approval in January of last year.
We also interviewed Dr. Varun Chaudhary to learn specifically about Faricimab treat and extend regimens in wet AMD patients who were enrolled in TENAYA and LUCERNE. How many patients achieved treatment intervals of 12 or 16 weeks? We'll learn more in this episode.
The AAO's IRIS Registry is a real-world database comprised of data from EHR systems. It's a massive resource for scientists seeking to better understand the dynamics of real-world patient behavior, physician trends, and overall outcomes.
It is especially useful, we're learning, when it comes to assessing the efficacy of therapies that are new to the treatment landscape. When it comes to wet AMD, that means performing an assessment of Faricimab's early returns in real-world patients. Dr. Durga Borkar was the lead author on an ARVO poster on that topic, and she joins us here today.
Dr. Borkar practices at the Duke Eye Center in Durham, North Carolina. Dr. Borkar, welcome to New Retina Radio.
Thanks for having me. It's great to be back.
Your study is called FARETINA-AMD. A handful of other studies, including the Truckee study and the Voyager study, are also examining the effects of Faricimab in the real world. What makes FARETINA-AMD so different?
One key highlight of this study is that it pulls from the IRIS Registry, which allows us to examine patients outside of a tightly controlled clinical trial setting. And it also allows us to look at patients beyond just particular centers that are used for retrospective analyses. In IRIS, we have over 540 million de-identified patient encounters, over 75 million de-identified unique patients, and there are over 16,000 clinicians who contribute. Also, updates to the IRIS registry are performed often, and the data lag continues to decrease. So we have snapshots of nearly current moments at this point. We think our study will help contribute to the overall body of literature on these early Faricimab results in conjunction with some of the other studies that you mentioned.
You identified 16,500 patients that received Faricimab for wet AMD from February 2022 to September of that same year. How many of them made the final cut for FARETINA-AMD?
Well, we included eyes with the documentation of neovascular AMD on their index date or entry into the cohort, and at least 12 months of data available prior to that entry date. We only included eyes with known laterality and demographic info that was necessary for the analyses. That left us with about 70% of the original set of patients, or 12,000 patients and 14,000 eyes. What we saw is that 87% of these eyes had undergone previous anti-VEGF treatment. The remaining 13% were treatment naive. This is obviously very different than what we see in clinical trials where all of the patients are treatment naive. And overall vision for real-world Faricimab patients was fairly good, with nearly half of them having better than 20/40 best documented visual acuity at the time of their switch to Faricimab.
What can you tell us about patients with a history of wet AMD therapy?
Well, the mean injection frequency in that 12 months prior to switch to Faricimab was about 6 weeks for the treatment interval. And what we saw was that about 2/3 of those treatment experienced patients had received aflibercept immediately prior to switching to Faricimab. Approximately half of these eyes with the treatment history had about 6 months of follow-up.
That covers eyes with a history of treatment. What about treatment-naive eyes?
Well, treatment naive eyes are a little bit difficult to assess at this point with only 6 months of follow-up because typically most of us treat neovascular AMD patients on a treat and extend regimen, and many of us give 3 loading doses, about 4 to 5 or 6 weeks apart. But we did see that 30% of treatment naive eyes had greater than 6 months of follow-up, and they needed a mean of 4 injections during that period. I do think, though, that we're going to have a better understanding of durability and treatment extension for these treatment-naive eyes the longer follow-up that we have.
Sure, understood. Now, one of faricimab's strengths is the increased likelihood of an extended duration that can reduce treatment burden. What did we see in real-world patients?
We limited our exploration of treatment intervals to patients with at least 6 months of follow-up at this point. What we saw was that about 2/3 of patients with a treatment history were extended to a greater than 6-week treatment interval. And 53% of those eyes experienced that extension in treatment interval after only 1 or 2 injections. And we saw that 76% of treatment naive eyes were extended to greater than 6-week intervals within that 6-month follow-up. And actually, 56% of those treatment naive eyes experienced that extended interval after only 1 or 2 injections, which is great since I mentioned before that oftentimes we are in those first 3 injections loading the patient. So what we really saw in these early real world results is that durability is pretty impressive and that we're often treating fairly refractory patients with faricimab in the real world currently. Hopefully we'll start to see as more treatment naive patients enter this cohort, as well as patients that maybe have only been treated with one prior agent prior to switch, that will have a broader understanding on the impact not only on interval, but also on visual acuity in a much more diverse set of patients.
When can we expect another cut of data from the study?
That's a great question. We're really excited about this study. At ARVO, we presented the results of our current cohort, which we plan to continue to refresh, and we'll be presenting these results on the podium at ASRS. I should mention also that we've done a parallel study looking at diabetic macular edema, and those results were presented at ARVO, and they'll also be presented at the ASRS annual meeting on the podium.
Excellent. Well, we look forward to hearing those updates this summer in Seattle. Dr. Borkar, thank you so much for joining us here on New Retina Radio.
Thank you so much.
Ample evidence suggests that treat and extend regimens for wet AMD offer the best of both worlds. Anatomic and functional results that are similar to those seen with monthly treatment regimens, but reduced treatment burden. Most of that evidence, however, focuses on anti-VEGF agents that retina specialists have been using for years. Now that a new treatment, faricimab, is available, we'd like to know how well wet AMD patients fare when undergoing treat and extend faricimab therapy. To find out, I sat down with Dr. Varun Chaudhary. Dr. Chaudhary is a professor of ophthalmology at McMaster University in Hamilton, Ontario. He is also the chair of the Retina Evidence and Trials International Alliance. That goes by the acronym RETINA, Retina. Dr. Chaudhary, welcome to New Retina Radio.
Thank you very much, Scott, for inviting me. Look forward to a discussion.
Let's be clear, we're not looking at real-world data here. We're looking at the Phase 3 TENAYA and LUCERNE studies, which were unique in that they had a treat and extend dosing model built into the study protocol. Tell us more about that.
So I think you bring up a very important point, Scott. As you know, we have been using treat and extend in clinical practice for almost a decade. This is the first time we have had a treat and extend paradigm in a Phase 3 pivotal trial where everyone was double mask. So it's a very robust methodology in terms of testing treat and extend. And of course, we also have this new agent, faricimab, that suppresses or binds to VEGF-A and Ang-2. So we're looking at a couple of new things, and that's why my colleagues and I wanted to do a deeper dive to really look at how treat and extend worked. So I think, as clinician, it's important to step back and look at the clinical protocol, the methodology used in the trial. And I think for me, 3 things stand out. Number one, let's focus on the control arm. So control arm was actually not a treat and extend arm. In the control arm in this trial, patients were given aflibercept every month for 3 loading doses, and then fixed dosing every Q2 months. Now, I think that's actually important to note because one of the assumptions of non-inferiority trial is the constancy assumption, meaning that the control arm should really give us the best results we can expect in clinical practice. And I think this control arm certainly lives up to that expectation. The second learning point for me is the faricimab, the treatment arm. And unlike some other treat and extend trials we've had historically, this was somewhat different. I think the goal here was to really use this dual mechanism of this new agent to first stabilize the disease in year 1, and then bring in this treat and extend personalized treatment algorithm to really help reduce the treatment interval moving forward. So how was this done? With Faricimab, there was 4 monthly dosing given. And then after that, at week 20, patients were assessed. And if they had active disease, they were put on Q8 dosing. Otherwise, they were assessed at week 24. If there were signs of disease activity, then they were put on Q12 dosing. And if they were still inactive, they were put on Q16 dosing. And they were kept in those swim lanes till week 60. And then after week 60, patients were then transferred to this treat and extend, personalized treat and extend algorithm. And the third learning point from the trial is the PTI algorithm is actually, very similar to, I think, what many of us do in clinical practice. It's somewhat pragmatic in how it was applied. Essentially, patients were extended every 4 weeks up to 16 weeks. The minimal interval was 8 weeks. The decision criteria for treatment was signs of active disease, whether it was anatomy or functional vision. So if patients had vision loss, worsening CST, new hemorrhage, that was defined as active disease, and the treatment interval was reduced either by 4 or 8 week intervals. If they were completely stable, they were extended. Or lastly, if they were in between, they were maintained. So I think those are kind of the 3 unique features of how this trial protocol was set up and how we incorporated treat and extend in these phase 3 trials.
The study design obviously resulted in fewer treatments for many of your patients over time. Can you offer me a few details about that?
Within the study context, for sure, it seemed like this concept of stabilizing the disease and then going to personalized treat and extend seemed to have worked quite well. Over the 108 weeks for the study duration, the Faricimab arm had a median of 10 treatments given, compared to aflibercept arm that had 15 treatments. Now, we need to remember aflibercept was not a treat and extend, that was a fixed dosing arm. But I think if we kind of look at clinical practices and other clinical trials, of course, cross-trial comparisons are fraught with limitations, but 10 treatments to control and achieve non-inferiority results is one of the lowest we've had in clinical trials. And if you also look at what happened in year 2 in the treat and extend arm, we really see a reduction in number of treatments. The Faricimab arm had a median of 3 injections in year 2 compared to aflibercept that had 6 treatments. And all of this was done in the context of achieving non-inferiority in terms of visual acuity outcomes and also achieving similar anatomic outcomes compared to the control arm.
So looking all the way at the end of the study, week 108, that tells us about the long-term effects of this treatment and this regimen. The study authors also looked at the first 3 appointments, so the first 3 months where patients received the same dosing irrespective of what therapy they received. So they've received monthly doses. What do they find when comparing the aflibercept and the Faricimab arms during those first couple of months?
Yeah, so the impetus we had to look at that was really, to control for the treatment algorithm and to see if there's a signal that this combined VEGF suppression and angiotensin suppression might be providing some value add for our patients. And this is post-hoc analysis, so it's supposed to be a hypothesis-generating exercise, but we did pick up some signals. If we looked at reduction in CST, at week 4, week 8, and week 12, during that match phase, Faricimab patients had a greater reduction in CST compared to aflibercept. Another signal we looked at was time to absence of IRF and SRF. So time to first absence of fluid in the central subfield. Because as you know, clinically, that's important in terms of clinician trying to decide when they can start treat and extend. And in the Faricimab arm, that happened for 75% of patients at week 8 or after 2 treatments. And in the aflibercept arm, that took place, that 75% achieved that endpoint at week 12, so 4 weeks later after 3 injections. So both of these suggest that there's a signal of a potential added benefit, and we certainly need further testing and hypothesis validation in future trials.
Okay, so we know then that the number of injections went down over the course of the study in the Faricimab arm. We know that the end of study anatomy and function were similar among aflibercept and Faricimab patients. And we know that Faricimab worked pretty quickly in the early periods. Let's talk about those patients that were able to be extended into long treatment intervals. So how many patients made it out to the 16-week interval in this study?
So in our analysis that we presented at ARVO, we looked at extended intervals and we defined them as either 12 weeks or 16 weeks. I think most of us in clinical practice would be quite happy getting most of our patients out there to those intervals. And in this trial with the Faricimab arm, 78% of patients got to that mark at the end of year 2, and 79% got to that mark at the end of year 1.
So roughly about the same.
About the same, exactly. About 80% of patients, close to 80%, got to that 12-week or 16-week extension. Now, what was also interesting is, what did treat and extend add in terms of value? And what we see is from end of year 1 to end of year 2, number of patients who were at 16-week intervals actually went up from 45% to 63%. So we see the benefit of treat and extend, at least in this trial, in the context of this agent, we could extend a large number of patients beyond year 1 into 16-week intervals at the end of year 2.
So it sounds like a significant number of patients were able to extend their interval during the treat and extend period, and I assume a significant portion of them maintained whatever long interval they were on.
Precisely. So, one question we have not answered in our field is we have many different treat and extend intervals. So what metrics do we use to assess a treat and extend interval? So for this study, my colleagues and I came up with this concept of looking at treatment decisions that are being made in the treat and extend period of the study. And there were over 2,500 treatment decisions made. So this is a decision every time a patient came to clinic: are you going to reduce the interval, maintain it, or extend? And what we found was that in 90% of these treatment decisions, patients were either maintained or extended in terms of the intervals. 10%, the intervals were reduced. And most of the time, this was based on anatomy and worsening of CST. So I think if we look at the purpose or the rationale behind treat and extend, we want to extend patients and maintain them at their appropriate intervals. What we don't want to do is reduce the interval, go back and forth. That's been associated with worse outcome, that fluctuating back and forth. And I think the fact that 90% of treatment decisions maintained or extended patients is certainly a promising outcome from the study.
Yeah, I agree. We're going to have a lot of Faricimab data coming in the next couple of years, and this is an important contribution. Dr. Chaudhary, thanks for coming on the show. We'll have you back soon.
Thank you very much, Scott.
All right, listeners, thank you for joining us on our first episode of ARVO 2023 coverage. If you haven't already subscribed to the podcast, please do so.
We have one more episode coming for you in the next couple of weeks, so be sure to be subscribed and tuned in.